Good evening. Welcome all. Thank you for joining us for tonight's special guest who will be joining us soon, and we will shortly get started. So thank you again for coming. We're grateful that you came to learn more from Dr. John Diaz. We're just waiting for our guest to arrive. He's joining us, so just bear with us. Good evening,
Tracy.
Dr. Diaz. How are you?
Good. How are you?
Good. Thank you so much for joining us tonight. We surely appreciate you coming on to share more awareness about cervical cancer for this month as we're here to highlight cervical cancer awareness. So
Thanks for doing this, and always for working so hard to kind of educate and spread it. Appreciate it.
you're welcome. Obviously when we first started, it was just about BRCA, and then we grew into, just having breast cancer, ovarian cancer, or one or the other. And as we've slowly learned, it's more than just what we know. It's cervical cancer awareness, it's ovarian cancer awareness. So bringing recognition to these days, I think, is super imperative, and that's part of our mission, is to continue to educate. So just a little bit about myself. I'm Tracy Milgram, the founder of BRCA Strong, where we continue to educate, inspire, empower, and advocate survivors, previvors, and thrivers. Whether genetically disposed or not, we're here for you and to eliminate the feeling of isolation and help you feel whole again. And we fund women post-mastectomy garments. So tonight, like I said, we have Dr. John Diaz coming on, who's a gynecological oncologist, and I will go ahead and pass it over to you to do an introduction.
Thanks, Tracy. So I'm a G1 oncologist, which means I specialize in taking care of women with gynecologic malignancies, cervical cancer, endometrial cancer, ovarian cancer, breast cancer. I also take care of women who have a BRCA mutation or other genetic mutations that put them at increased risk of developing these gynecologic cancers, and take measures to help reduce them from developing that disease. So Tracy's been great to bring me on, and I've really enjoyed talking with you guys about the different types of things we can do to help prevent ovarian cancer. We've talked about endometrial cancer. And with this being Cervical Cancer Awareness Month, I thought it was great for Tracy to think about the idea of being a previvor or preventing developing cervical cancer here in the United States.
Perfect. Maybe we could just start off with, what's the basic, what is the actual cervix?
Yeah. So it's funny, a lot of times when I talk with patients in my office, sometimes women don't know their own anatomy. So the cervix is part of the uterus, and it's the part of the uterus that connects the vagina to the uterine cavity. And it kind of acts like the door to allow entry into the uterine cavity. So it's what sperm has to travel through to fertilize an egg. When women aren't pregnant, which is most of the time, it's when it kind of keeps things out of the uterus. And when women are pregnant, the cervix is what keeps the baby inside until it's time for delivery. And that's when the cervix will dilate and allow the baby to pass through the cervix into the birth canal and for delivery. So it's really an amazing organ when you think about it. It's this little tiny, maybe $half size organ that can expand to allow passage for the baby for the birth canal.
Wow. So, when we talk about our cervix and why we need to see our GYNs, why is it important for us to see a gynecologist? Just in general, forget never, somebody who specializes in oncology like yourself, but why is it important for women to go yearly to be seen for a routine visit?
Yeah. And so that's exactly it. It's a routine visit, and every year you should see your gynecologist. Part of the visit is going to be the physical exam, where your doctor should look at the outside. So look at your vulva, look at the inside, look at your vagina, look at the cervix, do an internal exam, feel for any abnormal masses or anything like that. And depending on your age group or your past history, do a pap smear to screen for cervical cancer.
Okay. How do we screen? What are ways to screen for cervical cancer? Are there how do you guys guide us? I mean, if we're just coming in as, just a regular a well visit.
Yeah. So I think most women are familiar with the pap smear, right? And women kind of think that every year I need to go see my GYN and get my pap smear done. And so the pap smear is where we take and we kind of scrape the cervix a little bit, and we get some cells. And we're looking for those cells that are on the cervix to see if there are any abnormalities. And it's really revolutionized the way we prevent cervical cancer. And so in the developed world, like the United States, the UK, and Australia, these programs have really decreased the incidence of cervical cancer that we see. In countries where we don't have such great screening programs like Brazil or the Caribbean or China, that's where you'll still see these high numbers of cervical cancer. And what we started over the last couple decades is looking not only at the cells, but looking for high-risk HPV when we do these pap smears, with a combination of pap smears, which we call cytology, and also high-risk HPV testing.
When do we begin screenings for cervical cancer?
Yeah, that's a good question. So when I was a medical student, we used to say that you should begin screening once you become sexually active. Now that's changed, and over the last couple of years, the guidelines are to start screening at the age of 21, regardless of when you initiate sexual activity. And the reason for that is when we first start sexual activity, you're going to get exposed to HPV. It's just common. And when women are younger and they may have more partners, they're going to get exposed to more HPV. And most of the time, they're able to clear that HPV. In other words, it doesn't have any impact on them. So testing too early, we're going to get a lot of false positives. We're going to find abnormal pap smears or HPV that really isn't going to have any sequela for most women. And we know that from the time of first exposure to HPV to developing cervical cancer takes about 10 years. So we can wait till the age of 21, even if you start your sexual activities before that, because most of the time you're going to clear that HPV infection. And in those cases where you're unable to clear it, and that HPV infection can cause some changes, we're going to catch it when we start screening at the age of 21.
So it's okay. So, we talk about HPV, but maybe you could explain a little bit more about it and the vaccine and why we should vaccinate our children.
Yeah. So HPV is the human papillomavirus, and it's transmitted through contact, most common sexually contact. And there are lots of different types of HPV. There's some HPVs that can cause anogenital warts. There's some HPVs that can cause these changes in your cells that can become abnormal, and if left unchecked, could progress to cervical cancer and cancers in other areas like anogenital cancers, throat cancers. So we're seeing a lot of throat cancers diagnosed in men that are HPV related. And when it was first noticed that HPV was causing cervical cancer, it really was revolutionary in the world of GYN oncology. A lot of people didn't think, how could a virus cause cancer? So once we found that out, immediately the search came for, can we vaccinate against this? And so we've developed a vaccine, and there are actually 3 vaccines on the market. In the US, there's only one, the 9-valent, which protects you against 9 different HPV subtypes, including those that cause genital warts. And the idea is to get vaccinated before you become sexually active. So to offer this to our girls and boys around the ages of 10 and 11 before the onset of sexual activity, so that they can have this protection before they get exposed to HPV.
And are there any additional benefits to getting the vaccine? I know there's a lot of women out there and, moms and dads who have concerns about giving the kids the vaccine.
Yeah. So the benefit is that it protects you against this HPVs and the different kinds. And the reality is, if you are getting routine GYN exams and getting routine pap smears, the likelihood of you developing cervical cancer is very, very low. In the United States, only about 12,000 cervical cancers a year, despite the fact that almost all women are exposed to HPV. So it's really uncommon in the US. And the reason is because we have these effective screening programs. But it also protects you against developing genital warts. And I've had to deal with a couple of pretty severe cases of genital warts in young women. And that can be both emotionally and physically devastating sometimes to have to resect these. And it protects you against the precursor lesions. So you have less of a risk of developing these abnormal cells that require biopsies or sometimes bigger biopsies called conization, which can have some impact on future fertility. So really, it's recommended for girls and boys. I have 2 boys, and they've been vaccinated. And the concept initially was herd immunity, which we've all been kind of familiar with now because of COVID-19, what herd immunity is. But as we've learned more and more about the risk for heterosexual men to develop HPV-related tumors, particularly head and neck, and certainly homosexual men develop HPV-related tumors, it's a good idea to vaccinate our boys to protect them against HPV-associated vaccines. Because women, we do screening for cervical cancer with pap smear, but for men, we don't really do any screening for head and neck HPV-related cancers, and we really are very early on doing any kind of screening for anal cancer related to HPV. So again, all boys, all girls should be offered HPV vaccination before the onset of sexual activity. But even if we miss that opportunity, there's still a benefit to being vaccinated, even if in your 20s. And when the vaccine first came out, it was approved for patients up to the age of 26. 2 years ago, the FDA extended that to patients to the age of 45. So again, if you didn't get vaccinated during your 30s, and perhaps there's concern about new exposures, it may not be a bad idea to talk about it with your GYN or your primary care physician. If you'd be a candidate, would you benefit from the HPV vaccine?
And what about for men? Do they receive this vaccine? I know you said your boys, but what about like the men? Do
Yeah.
they get this vaccine?
So men can get the vaccine. And again, we don't screen really for male-related HPV cancers. So men are at risk, and men should be vaccinated. And if you're between 26 and 45, depending on what your risk factors are, you should talk about getting vaccinated with your primary care physician.
And how is this vaccine administered?
So if you get it early, it's only 2 injections, and then it's given about 6 months apart. If you get it after 15, then it's what's called catch-up vaccination. So you'd get a vaccine, 2 months later you get a second dose, and then about 6 months you'll get your third dose. So again, ideally you'd want to get your children vaccinated before the age of 15. It's only 2 shots. That was a big selling point with my oldest son. So,
this is very interesting question that I have, because it comes up all the time. I know in our BRCA group and our private group a lot is, if you've had a hysterectomy, do you still have to go in for a pap smear? Is there a protocol?
So it's something I talk about with my patients. If you have a hysterectomy, you still need to see your GYN every year. And a lot of them will say, well, John, why do I have to go in? I don't have a uterus, I took out the ovaries, what am I looking for? And what you're looking for is still the outside of the vulva, which can develop these changes, the vagina, okay? And again, feeling for any abnormalities. So it's great to see your primary care doctor and your internist, but sometimes they may not be as comfortable with the general exam. And so even if you've had a hysterectomy, you still need to see your GYN every year. Specific to pap smears, it depends. So if you've never had an abnormal pap smear, and you have a hysterectomy for, let's say, fibroids, so not for a cancer, then per the guidelines, you don't need to have pap smears anymore. Now, most gynecologists and most primary care doctors don't follow those guidelines, and that's okay. They're being a little bit more proactive, but your likelihood of developing vaginal cancer, which is really what we're looking for, is very, very low. Now, if you have maybe a new partner or new exposures, then you should continue with screening.
Okay. What is the cervical cancer that was discovered? What's the treatment? Is this caught, you're diagnosed with cervical cancer and it's discovered, what's the treatment for that?
Yeah. So if you're getting your routine cancer screening, so pap smears, then we should catch this at an early stage. And the treatment for early stage is surgery, doing what's called a radical hysterectomy, where you remove the uterus with the cervix and kind of the surrounding area. If unfortunately you're coming from outside the United States and you haven't really had pap smear screening, or if you live in the United States and just haven't had cancer, it's likely you probably won't get attention until you become symptomatic. And by that time, you may have a locally advanced or an advanced stage cervical cancer. And the treatment for that is usually radiation therapy. And that's one of the biggest challenges, is trying to talk to my patients who have advanced cervical cancer and explaining to them that I'm not going to operate and that's not the correct thing to do for them. And they have a really difficult time with that. It's understandable. But those patients really should be treated with definitive radiation therapy.
Is there a role for immunotherapy if cervical cancer is found, and what is immunotherapy?
Yeah, it's a great question. So immunotherapy is pretty exciting in the world of cancer. Basically what happens if you have a cancer in your body, it doesn't belong there. And just like if you have an infection or an ingrown hair or something like that, your body should recognize that this doesn't belong there and should attack it and remove it. And it's not happening. The cancer cell is hiding from your immune system. So there's a type of immunotherapy called immune checkpoint inhibitors, and that's the one that patients or people are usually talking about when they talk about immunotherapy. And what that does is it kind of unmasks the cancer, and it now makes it visible to your immune system. And it also stimulates your immune system to attack and eliminate those cancer cells. And so the most experience we've had with this has been with lung cancers and melanomas, but now it's been expanded. So pembrolizumab, which is a type of immunotherapy, an immune checkpoint inhibitor, was the first drug that was approved by the FDA, not based on treatment for ovarian cancer, breast cancer, but based on treatment based on a marker. If you have what's called MSI high. And that's really revolutionary. So again, now we're attacking cancer, not by the type of cancer you have, but by having this marker. So there's a role for immunotherapy in cervical cancer. And those cervical cancers that have a biomarker, which is called PD-L1, we know would respond to immunotherapy. So right now it's used for patients who have recurrent or metastatic disease. We're looking now at combining immunotherapy with radiation therapy for the treatment of upfront cervical cancer. So the role of immunotherapy in cervical cancer and in all cancers is really evolving.
And how is this given? How's the immunotherapy given? Is it through a port? Is it through IV? How's it administered?
Yeah, so it's an infusion, so it goes in your veins, so it can be given via an IV, so directly into the veins, or many of our patients will have a port placed just under their skin here, and it can be infused out. It's a quick infusion, and depending on the dose, it can be given every 3 to 6 weeks.
You know, how does cervical cancer relate to the BRCA gene or any of our genetic mutations?
Yeah, so that's a great question. So right now, cervical cancer really is related to HPV infection. Um, and there's not, that we know of right now, a genetic predisposition to cervical cancer. But like we talked about, we're all exposed to HPV. And for some reason, there's some women who are unable to clear this HPV infection. So could we in the future identify what gene limits a patient's ability to clear its HPV infection? And is that going to be something that we will be able to identify in families? Maybe. But right now, we know it's HPV infection, so it's not something genetic, but you may have some genetic that may make you more susceptible to that HPV virus or less able to clear it.
You know, one question I received is if you are an ovarian cancer survivor and have children, what age should you start screening them? And is there we know there's really no early, prevention for ovarian cancer, right? But what do you recommend for the moms out there that are saying to us, when do we screen our children for ovarian cancer? She's going through puberty, she's getting her period, when do we screen for those screenings?
Yeah. So ovarian cancer, as you know, Tracy, may be related to genetic mutations. And we used to think or only know about BRCA1 and BRCA2. But as you know, we've identified a lot of other genetic mutations that can place women at increased risk of developing ovarian cancer. So any woman diagnosed with ovarian cancer should be referred to a genetic counselor. And I would recommend to undergo genetic testing and see, can we identify, or do they carry a gene that puts them or their family at increased risk? And obviously, if we do, then there are certain guidelines depending on which gene you carry about when to initiate ovarian cancer screening. Understanding, like you said, unlike breast cancer screening or cervical cancer screening, we don't have effective ovarian cancer screening. We do ultrasounds and we use the CA-125 blood marker, but none of those have ever really demonstrated to be able to do what we'd like it to do, which is to catch an ovarian cancer early when it's treatable and curable. So if you have ovarian cancer and you don't carry a genetic mutation and you're worried about your daughter, one thing we know is that birth control pills decrease your risk of developing ovarian cancer. So if you have a daughter and you guys do not have genetic mutation in your family, birth control pills for more than 5 years decrease your risk by 50%. And then it will be a discussion with your gynecologist as far as what are the benefits of screening versus what are the risks. Again, identifying an ovarian cyst, which is likely not going to be a cancer, which might lead to unnecessary surgery and things like that. So Unfortunately, right now, we don't have effective screening for ovarian cancer, but we do have effective chemo prevention. And by that, I mean the birth control pills, which again decrease a woman's risk by 50% of developing ovarian cancer.
You know, we talk about the medical field, how it's advanced and technology's changed so much and we've grown, maybe we could talk about some clinical trials and how we need more women to participate and the importance of it and like what's coming down the future for cervical cancer. Maybe we can highlight a little bit of that to educate some of these women and let them know that there's opportunities to help themselves and to help others. I'm a true advocate of clinical research. I feel like if I cannot help myself, but I could help others, I want to do it. So if it means going into a trial and either going under monitoring or surveillance or medications, what can we do? So maybe if you want to touch base a little bit on like why clinical research is so important and maybe what you're doing right now and the advancements that are coming to educate the women that are out there. I mean, I know PARP inhibitors weren't around 5 years ago, now they're around and the different developments that are coming.
Yeah. So clinical trials are really important, Tracy, and that's a passion of mine. So I lead the clinical trials program for gynecologgy at the Miami Cancer Institute, and we developed a pretty robust portfolio of clinical trials. Specific to cervical cancer, I have a clinical trial that we developed looking at the combination of immunotherapy, which we had talked about before, and also PARP inhibitors, which you just mentioned. And so the idea is in those women who have recurrent or advanced cervical cancer, with our trial, we combine immunotherapy and PARP inhibitors for the treatment of this disease. And the reason we chose that is to kind of attack the cancer cells from two different approaches. PARP inhibitors work differently than immunotherapy. And what's also really exciting about this trial is we did a previous trial with immunotherapy and we found a new biomarker with our colleagues over at Florida International University, where we identify a marker in the FACSI pathway, so Fanconi pathway, that could predict those women who would respond to immunotherapy. So as I mentioned before, pembrolizumab was the first drug to get approved with an MSI high signature. We identified another biomarker signature that in our cohort of patients identified who would respond. For our clinical trial, we're going to use that combination and also look to see if that biomarker again identifies those women who responded in our clinical trial.
Maybe you want to go into a little bit like why we need so many more women to participate to help us research and have more data out there and efficacy of these, products that work and help women or their surveillance, either kind of clinical trial. Obviously, there's different phases from 1 through 4, but, I know there's a lot of question of women and hesitation to why they should participate. Maybe from the physician standpoint, you could just go into a little detail on like why we need more women to come into these trials to help us make a difference. But from the clinical aspect of it, maybe it could be explained a little different.
Yeah, so like you said, there are different phases to clinical trials. Phase 1 clinical trials are basically a new drug, and we're not sure if that drug is going to be effective. And we're basically trying to learn is that drug, what are going to be some of the side effects with that drug, and what's kind of the safe dose to use that drug. So the benefit for patients to go on a phase 1 trial is they're going to have access to a medication that may not come to market for 10 years. And so if we have access to it, you can have this drug, which may work. And if it doesn't work, then you can go back to more traditional therapies. So for example, like you said, PARP inhibitors. PARP inhibitors have revolutionized the way we treat ovarian cancer. They're now being treated in breast cancer, prostate cancer. As I said, we're using it in our own clinical trial to be looked at for endometrial cancer. When I was a fellow at Sloan Kettering 14 years ago was when we first started a phase 1 trial with PARP inhibitors. So it's taken 10 years for those drugs to come to market. So that's the benefit of a phase 1 trial. Once we find out the safety of that drug, we then move on to a phase 2 trial. And basically now we're saying, okay, is the drug effective in this disease site? And so we know it's safe. So now we're going to learn a little bit more about safety, but we're going to look particularly in ovarian cancer or in cervical cancer. Does this drug work? Once we know a drug works, then it goes to a phase 3 trial. And that's where you compare this drug to the current standard treatment, or sometimes to a placebo. So phase 3 trials really are the best trials to see how effective a drug is. They're also sometimes the most challenging trials to put patients on. because oftentimes you get randomized to a placebo. In other words, you're not going to receive the study drug because we want to see, is it better than what we already have? And a lot of patients don't like the idea of not receiving the drug. So that was make it challenging with phase 3 trials, but all of them are so important to advance research. And the challenge in GYN cancer is, thankfully, we don't have a lot of patients. Like I said, we have 12,000 cervical cancers a year. We have 22,000 ovarian cancers a year, and we have about 60,000 endometrial cancers. Compare that to breast or lung or colon, where the numbers are much larger. So patients are our most important research in doing clinical trials. And the other challenge is funding. Women's research for cancer, with the exception of breast cancer, is way underfunded compared to other cancers. And so we really need to work awareness through how do we fund these trials to help advance the treatment for women with GYN cancers.
It's interesting on the advancements, like you said, and how far we've come, like PARP inhibitors and all these medications and the different ways that we can help these women. So, maybe we can close out by 2 comments from you that basically can remind women, of like what they need to do to prevent cervical cancer, because there is ways to prevent it and there is things that we can do. So maybe you could close out with 2 ways that women can prevent.
So I think one of the important things for women is it's okay to be selfish sometimes. And women are usually the first one to sacrifice themselves, to take care of their family, to take care of the ugly parents, to be that care provider. And the first thing they do is they stop going to see their doctor for their own routine appointments. And that's where we see these advanced cases, particularly cervical cancer, that really can be avoided with routine screening. So take the time for yourself to see your doctor, to make sure you get your routine health done, your screening mammograms, your screening pap smears, your colonoscopies, and don't forget about self-care. We talk a lot about cancer, and rightfully so, and that's my passion, but the #1 killer of women in the United States is not breast cancer, it's not ovarian cancer, it's heart disease. And things that lead to heart disease, being overweight, poor diet, you don't go to the doctor, check your cholesterol, you're not making time for yourself for exercise. So take those 30 minutes every day and go for a walk around the block. Do a Pilates class. There's so many things online now to make time for yourself, and self-care is so important. So again, self-care, take care of your heart, and do your screening tests, and really worry about yourself. You can take care of others too.
One question we just got was, why is women's healthcare so underfunded? Like, why is, like compared to the other cancers, why is ovarian cancer not funded as much?
Yeah. So one is numbers. Like I said, thankfully there's not a lot of ovarian cancer, there's not a lot of cervical cancer. But what's frustrating is prostate cancer, which doesn't really kill a lot of men. Men die with prostate cancer, not from prostate cancer, is one of the highest funded cancers for research. So you can guess why that gets such much funding and women's cancers get so little funding. So we need to be advocates. We need to go out there and demand that women's cancer and women's research gets advanced and gets the appropriate funding that it needs, because it's so important.
Well, thank you so much for coming on. I truly appreciate having you on tonight. And if anybody has any questions and was not able to ask, you can feel free to message me or message Dr. Diaz, as he's on our Instagram page. You can make sure to follow him. He posts updates, clinical trials, and all kinds of events that he's doing. So thank you so much, Dr. Diaz, for coming on. It was great seeing you. We appreciate your dedication and commitment to helping us make a difference in our community.
Thank you, Trace, for everything you do, and I'll see you soon.
Perfect. Take care.
Bye-bye.
Bye-bye.